Thanks everybody. Thanks everybody for joining us for the second installment of our care of the LGBTQ plus patient. And remember last time we discussed a little bit what all the acronym means, how to kind of nomenclature for this special group of patients, and how we as providers can tailor our care for the patients just by knowing a little bit about their background and where they're coming from. Again, just as a note of kind of housekeeping in a way, I'll probably just refer to the patient as a queer patient or a gay patient, just because the acronym tends to be a little bit tongue-tying. So we didn't go into the numbers very much last time, but this population does represent a significant proportion of the people that we see. So about 4.5% of the American population identifies themselves as LGBT. And this was based on a Gallup poll. If you look at millennials though and break this group down, it's nearly double. So obviously the younger generations, as you know, society has shifted, have felt much more comfortable with this self-identification, more so than probably the old population. I think this is just people naming themselves or free to name themselves as they wish, as opposed to really any change in our demographics, you know, true sexuality. In my area here in Tampa Bay, it's about 4%. Our population here is a little bit older, as everybody knows, so we tend to have, you know, a little bit lagging in the millennial category. But the important thing from a research standpoint is that the Institute of Medicine, the American Medical Association, National Cancer Institute, National Institute of Health have all designated this group of patients as a health disparity, much like African Americans or Latino patients are all health disparity. And what this does is it opens up a lot of funding, because now every time there's a supplement to a grant, especially, you know, if you have an R01 or U54, sometimes there'll be a supplement addition, and that supplement will be earmarked towards health disparities research, including LGBT populations is into the health disparities subgroup, does allow you to open up some additional funding mechanisms that would apply to this research population. The important thing and why they did this is because, as we'll touch on in a second, there's very, very few data regarding clinical care of the LGBT patient. So research is needed. So I think that's why these numbers are going forward, going to be so important for research. So just a little bit about the group and their medical care so far. We can expect about a little under 18% of them to be uninsured. Now that, you know, gay marriage is legal, marriage partner benefits are obviously still held by most companies, but partner benefits are not. There's still an overwhelming drive among this population to be partnered and not be legally married, in which case it's up to each individual employer whether or not they wanted to give partner benefits. For instance, at my institution, I work for a state institution. The state of Florida does not give partner benefits. So because I worked for a state institution, our institution did not give partner benefits until we appealed it. And then, you know, the university actually kind of stepped in. But given it's a state institution, state laws apply. So this is something that's going to be corporation by corporation specific. And also, you know, when it comes to insurance, even if you have insurance, many of these patients lack coverage that they need in order to do gender affirming treatment. We talked about last time a little bit about what goes into the transition during a transgender patient's, you know, transition from gender, and that this may or may not be covered. So what we're including here are hormones to be taken on an ongoing basis, obviously surgery, which is something that we would get into, and even cancer screening. So if you're, you know, if somebody has changed their biologic sex on their insurance documentation, passport legally, but they still have organs of another gender, then cancer screening for that other gender organs may come into issue. Who's going to pay for that? You know, why is a male getting, you know, a hysterectomy or a pap smear, cervical pap smear, when they're biologically male? So obviously that will come into a lot of insurance questions and can impact someone's screening options from an insurance. But the patients themselves also have a play in why their healthcare is so disparate. And about 30% of this population kind of avoids going to the doctor for various reasons, which we can get into, but many of them do not have a primary care physician. Many of them don't feel comfortable with their current patient-doctor relationship. They may or may not feel comfortable actually coming out to their doctor. And some of them have feared that their doctor may or may not know how to treat them well, which is why these kind of sessions are so important. So we can advertise and educate physicians on how best to treat the patient to get them more comfortable and to get them the care they need. The population itself has unknown risks. So they don't know what they don't know in a way. And oftentimes in many of the health literacy campaigns, we've identified that many of these patients have underestimated their true cancer risk. Let's take, for instance, which we'll get into here in a minute, but a lesbian woman has underestimated her risk of cervical cancer due to various factors. So that would make that patient less likely to get cervical cancer screening. Behavioral issues such as smoking and drug use also increase someone's health issues and need for further care, and further dividing the health disparities issue. And then lastly, there's a lot of comorbidities associated with this population, such as obesity and psychiatric. The risk of psychiatric illness in the population is about 4 times other populations. And recent estimates have said that a transgender teen has about a 40% risk of having at least thought of or attempted suicide in their adolescence. So obviously psychiatric issues are at the forefront when treating this population. When it comes to cancer specifically, which is where we'll go with the rest of the talk, and obviously my area of concern, remember that our individual's risk is based on their current anatomy. As I mentioned before, I don't care what gender your box says. I don't care what gender you say. I care about what organs you have and where the cancer can arise. And as clinicians, I think we should focus our attention based on current anatomy. We name something called an organ inventory when we see these patients for the first time in our clinic. And we recognize that patients may have altered anatomy based on their assigned or chosen gender. And what we want to do is identify, well, what organs does this patient currently have that still needs screening? And that is part of our so-called organ inventory. The next things we look at are any social behavioral features or factors that may influence their risk, such as smoking and other activities. For instance, we did a study here in Tampa looking at sun-seeking behaviors, and we know that men who have sex with men have much higher sun-seeking behaviors. They tan more, they go to the beach more. So obviously the risk of melanoma increases. So this is a social behavioral factor that increases the MSM population locally in Florida for having increased risk of melanoma. So that's just something kind of here in our little microcosm that we've been able to identify and obviously gear towards campaigns targeting this particular behavior and this particular population. Oftentimes, patients may not relate with their anatomy. As we've touched on already a couple of times, a transgender female will likely not relate with the prostate that is probably still in situ. So when they think of screening, they don't think of that prostate as part of them because that's a dead organ to them. And they may not even admit that the prostate is still there, but remember, in most transgender surgery, the prostate is left in place. So that's something that we have to, as clinicians, identify to the patient and remind the patient that that still needs some sort of screening. This idea of transitioning not having a beginning or end that we discussed last time holds true here as well, where the organ inventory is very important. I'll touch base on just a couple of cancers real quick that kind of speak to the issue more so than the other ones. And ovarian cancer probably leads our discussion when it comes to lesbian women. Lesbian women have lower rates of contraception, lower rates of pregnancy, higher rates of obesity, which is a perfect setup for ovarian cancer, as we all know. So their guidelines right now are to screen these patients based on standard guidelines. And the reason is because we don't have enough data on lesbian women. So I'll digress for a second, discussing how we come up with some of these data points. And up until this point, I could not tell you how many women at my cancer hospital with ovarian cancer identified as lesbian, because that was never really part of our query. So I could never pull those data, and we could never then identify a true relative risk. As of a couple of years ago, most large institutions have moved towards that. Medicare is going to start requiring that of most hospitals to identify sexual and gender information called SOGI data in our standard uptake of patient demographics, in order so that we can identify a true relative risk. But up until this point, excuse me, up until this point, we couldn't answer that question, so we couldn't alter the guidelines. Ovarian cancer is a true one. Although the women with ovarian cancer tend to have all the risk factors associated with ovarian cancer, there are no standard guidelines for lesbian women different from straight women. Nonetheless, we do recommend, obviously, that these women undergo routine screening. Breast cancer and cervical are much the same. Lesbian women have a 1.43% increase lifetime Gale score, and again, due to the same issues: nulliparity, obesity, alcohol intake, with standard screening guidelines. So I think the important thing is just to get these women to screen in any way, because oftentimes these women don't screen enough. Cervical cancer is one that we touched on a little bit, which is kind of the double-edged sword. So in general, lesbian women tend to have less HPV infections than straight women do. But this risk of HPV is not zero, because these women oftentimes can spread HPV among each other. Oftentimes, these women have had prior heterosexual experiences or shared toys, in which case the HPV can spread from one person to the next. When these women do get HPV, they have the same cervical risk as any other woman would have. However, the misconception that's common in the lesbian population is that because they don't generally have sex with men, they think they cannot get cervical cancer because they are at lower risk for getting HPV. True, but the problem lies in screening. So because of this fallacy, then oftentimes lesbian women have lower rates of screening, thinking erroneously that they have relatively no risk of cervical cancer. In that sense, what that leads to is higher cancer rates, because these women still have a risk for HPV, kind of deny their risk or underestimate their risk, don't get screened, and end up getting cancer because of it. So the Women's Health Initiative study, which is a huge study looking at cervical cancer and HPV in women, broke down based on sexual orientation. They found that cervical cancer was present in about 1.3% of women who have sex with men, almost double, 2.2% in women who have sex with women, and bisexual women, again, about the same, 2.1%. So, we can see that it is still a major health issue among lesbian women, even though it's often underestimated. So again, we recommend based on organ anatomy. So screening should be based on having a cervix, not how you use your cervix. When it comes to prostate cancer, we know that gay men tend to have lower rates of cancer screening in general, but there's a lot of unknowns with this. So we know that prostate cancer is largely hormonal, but we don't know what the use of hormones has to do with these patients getting prostate cancer. There's an increased rate, of testosterone use among gay men, both legally and illegally. There's a higher rate, of propecia for hair loss among gay men than straight men. And we don't know the interplay between HIV and prostate cancer, which has emerging as a true issue when it comes to treating older gay men. We do know that there are similar survival outcomes among both groups, but the biggest thing that comes to play when treating a patient, a gay man with prostate cancer, is the different social and lifestyle needs during and after treatment. Oftentimes, the gay man needs more social support during treatment, especially during radiation. That's been well documented. And they have a lot more side effects from the radiation while on treatment than the straight man does. So these patients need specialized care to help them get through their treatment. What we've started, and I think a lot of hospitals have started, is a nurse navigator program. Our nurse navigators help these patients through their treatments. And a couple of our nurse navigators are specifically trained to treat the LGBT population, so that when they have a patient, such as a gay man going through prostate cancer therapy, they know the specific issues that this patient may have and can kind of tailor their patient's navigation to the issues at hand, specific to that population. Now, something that we'll spend a little bit more time on and probably germane to the group is anal cancer. Now, I know this is something we all know well, and some of this is a little bit more or less controversial, but we'll go through some of it here. I'm not intending to, spend a lot of time talking about the pros and cons of different anal cancer screening or not screening, just more so highlighting the role of our role in helping our LGBT patients identify their personal risk for anal cancer and what we can do about it. So we do know that anal cancer is HPV related, with about 90% of anal cancers being HPV mediated. Among those, we know that men who have sex with women, about 15% of them have HPV infections at the anus. Men who have sex with men, about 60% of them have HPV infections of the anus. And among HIV positive men who have sex with men, this is our highest risk group. 90% of them have HPV associated infections of the anus. This risk increases with the number of sexual partners. So it is probably a factor of multiple things. So it's probably who you have sex with, how you have sex, underlying comorbidities, and the number of people you have sex with. And those probably all go into this algorithm of an individual's risk for anal cancer. Now, as we all know, it's not just gay men that get anal cancer. I mean, in my clinic, it's mostly straight women, honestly, but we see a lot of straight men with anal cancer as well. Just in my practice, that tends to be less HPV mediated, but we see plenty of straight men with HPV associated anal cancer, obviously treated just the same. I even had a patient one time come in with his wife, and the wife was ready to, divorce the husband, thinking that she or that he had been cheating on her with a man, and my job was not to discern whether or not he was cheating. My job was just to inform them that it was, likely a multifactorial infection, not just attained by gay sexual intercourse. So what we have here in our program, in our local area, is a screening program. We utilize anal PAPs and we utilize high resolution anoscopy. I know this probably varies from provider to provider and region to region, but this is just what we have chosen to do here in our area. So what we did here in our Tampa Bay area, and I would encourage different metropolitan areas to do something similar if they don't already have one, is we had a little bit of a roundtable with the largest largest HIV providers and the largest gay population healthcare providers in the area. And we came down to it and asked people, well, how are you currently treating or screening for anal cancer among this high-risk population? Again, 90% of our HIV positive MSMs are going to have HPV disease. And what are we doing about it? And what do we want to do about it? So it was a lot of ID doctors, me and maybe another colorectal surgeon, and then some primary care doctors that focus primarily on gay health. In addition, we had the health department had a representative at our little round table, as we have a gay clinic, a free gay clinic here called Metro in downtown, and they had a couple of representatives as well. So we had all these stakeholders, and everybody says, yes, we recognize that we as a community should do something to screen this high-risk population. But what happens is that the primary care doctor said, well, I'll do an anal PAP in the office, and then when it comes back, I don't know what to do with it. Or I don't want to kind of take that next step. So what we realized is that there was a lack of continuity of care, and there was a lack of referral to that next group. So what I said is, well, as a cancer center, we're happy to take that role and quote unquote, hold your hot potato. So when the anal PAP comes back anything other than abnormal, we have a nurse practitioner that then reviews those pathology results and then recommends a patient to come in or not come in for further care at our institution. So a lot of times it takes a little bit more of a concerted effort than the existing pipelines, because this is a special population that needs kind of that next step level care in terms of handholding. So what we did is we developed a little bit more of a continual pipeline for patients to get screened in the periphery and then filtered down with positive screens to the cancer center or to the colorectal surgeon provider. So that, served us in both ways. One, it was a great source of patient volume, because here we have a steady source of patient volumes, largely easy to treat patients that are oftentimes just treated by my nurse practitioner. So that's how we run our LGBT anal cancer screening program here. But of course, there are different models in different cities which all work equally well. Remember, the HPV vaccine is currently recommended for patients under 45, and we liberally use this. We have a couple of studies. I happen to work at a center where we have a lot of HPV research. So we are currently undergoing a trial right now on HPV vaccinations over the age 45, and showing some promise, also showing some significant promise on the therapeutic effects of HPV. Again, this is all off-label use until research kind of gains traction, but we'll keep this in mind as we go forward, looking in the field, because I would expect some changes in the way we vaccinate our patients going forward. Right now, in our off-label use of HPV on trial, we are vaccinating all HIV positive men. Again, there's very limited research in this area because up until a few years ago, I couldn't tell you how many gay men I was treating in my practice, and I see a fair bit. So in order for us to query that, I would have to physically go into each chart where I said this is a 45-year-old gay man. Now we have a little bit more of a codified EMR-based system where we can identify and query sexual orientation from our EMR platform. And most of the big EMR platforms now have moved toward this, given the Medicare requirements. As we all know, the ANCHOR trial, specifically looking at high-resolution anoscopy and its use in anal cancer prevention among HIV-positive gay men, has concluded with good results. The data haven't been published, but the kind of tagline was already published that they did show a difference. So we're all eagerly awaiting the group from UCSF to publish their final data, but at least preliminarily, it looks like in their hands, high-resolution anoscopy did show promise in preventing anal cancer. Again, we'll wait to see the final data before calling judgment. And lastly, we do know that this population has worse outcomes. So when you compare, the two biggest groups that we see with anal cancer, one being a heterosexual straight woman and one being a gay man, especially with HIV, we know that the gay man with HIV will always have worse prognosis than the straight woman when it comes to anal cancer, something that we need to be very, very careful of and attentive. We also know that among HIV positive men who have sex with men, we should not alter our therapy, meaning we should not dose to reduce, we should not de-escalate our radiation therapy, as had been thought in several years ago. That was the case. We know from more recent research that that's not the case whatsoever. For those people who come in with a more aggressive cancer, we should be equally as aggressive in our therapy, which ties in pretty nicely to HIV. So we know that patients with HIV have higher risks of cancer in general. We and many institutions are part of the AIDS Malignancy Consortium, which investigates the intersectionality between HIV and its risk in cancer. And we know that HIV not only affects anal cancer, as we've been talking about, but for my thoracic colleagues, it increases the risk of independent risk of lung cancer, risk of lymphoma, risk of Kaposi sarcoma. So there's several associated HIV-associated malignancies that are on our radar. So obviously controlling HIV does have significant cancer impacts on a societal level. So what we recommend is that men who have sex with men and trans patients should be screened annually for HIV. We consider extensive use of PrEP, or pre-exposure prophylaxis. Truvada is the common trade name, and our local community docs often prescribe that. I don't prescribe it personally, but if I have a patient who should be, in my opinion, on Truvada, I'll refer them out to the primary care physicians that I know in the area that do go ahead and prescribe and monitor its use. We offer, of course, early education for cancer risk among HIV patients. We do standard patient education seminars and brochures at our HIV clinics, both through the ID community and our free health department here in the county, to tell patients about their exposure to HIV risks, and more importantly, their cancer risk once they're already infected. It's often underestimated by both clinicians and especially by patients that having HIV does increase their risk for not only anal cancer, but a multitude of cancers, as we've discussed. Unfortunately, HIV rates are increasing. This is just a local slide here, but my state leads the country in new cases. My local area is the highest in terms of areas of concern that the government has said are needing attention in specific. Our breakdown of HIV, new HIV cases among different proportions or different sections of our society is 43% among white Tampanians, we call them, people from Tampa, 35.8% among Black citizens of Tampa, and about 18% Latinx here in Tampa. So as we can see, it's equal opportunity that kind of more or less mirrors our racial background of the city in general. So it's not too different than just walking on the street or going to the mall. So we can see everyone's affected by HIV in my local area. So it's kind of erroneous to say that it's a one-size-fits-all population, because when you do your education for these on a public health standpoint, we try to trigger this intersectionality of the Latinx HIV positive patient and try to hone in on the needs of that patient and how to get that patient into further care. When it comes to age, unfortunately, young people accounted for 22% of all these infections. So we're looking at 13 to 24-year-olds just starting their life account for 22% of all new infections of HIV here in Florida. Of those, 81% are young gay men. So obviously this is a huge area that needs attention, because this is a very preventable group with education. If you can get these kids on Truvada early on, you may be able to really impact their life going forward. As we talked about earlier, some of the associated cancers with HIV are anal cancer, as we all know, lymphoma, Kaposi's, lung cancer, cervical cancer, HCC, skin cancer, and oropharyngeal cancer. In addition to HIV, obviously sexually transmitted infections have a large role in someone's cancer risk and overall health risks as well. As colorectal surgeons, we are often on the forefront of seeing patients with sexually transmitted infections, especially in the anal and rectal manifestations, especially when it comes to chlamydia, gonorrhea, and syphilis. That's what we'll see the most. We are responsible for treating a lot of these patients when they come in with their discharge, itching, pain symptoms, so that we know how to appropriately treat them. Again, I'm a liberal use of immunizations. We do screen patients accordingly when they have symptoms. We do screen for all of them whenever they come in for symptoms, I think as we all do. And we do screen based on individuals' risk and sexual proclivities. This is overall just kind of a screen that I like to share with the different populations that we treat and how we should be screening them from an infection standpoint, and then obviously from a multiple care standpoint. We do, for our gay male population, we do screen for STIs once a year. We do offer the vaccine. This is a little bit older. I apologize, that we do offer now under 45 off-label. Then we do immunize as much as possible and continue our cancer screens just like everyone else. Among the trans population, this is where it gets a little tricky because the guidelines are very, very scant. Our role here is to do breast cancer screening based, again, on organ. Depending how much chest wall tissue these patients have, we screen or examine just like their cisgender counterparts. We don't know what the role of hormone use has to do with breast cancer. So we do increase their screening just a little bit. Oftentimes, this excessive use of hormones does alter the architecture of the breast tissue. So our breast program here tends to use a little bit more in MRI, or a little bit more investigative therapies as opposed to a standard mammo on these patients. But again, I refer all of those over to our breast program, who is much more sophisticated than I am in screening these patients appropriately. When it comes to the clinical care, as we touched on last week, I tend to ask very open-ended questions. Instead of asking, are you gay or straight, I just ask them, well, how do you describe your sexuality? For most people, they will answer that question very honestly. For some people, I can understand they're a little cagey about it, but that allows them to describe who they are in terms that they understand and they recommend. I'm also very comfortable, I think as we all are, there's very little stories that we haven't already heard. There's very little activity that goes on in the bedroom that we haven't already learned about from other patient experiences. So I think we're all pretty comfortable about hearing whatever answer they may come at us. So, if you ask a question, expect an answer. And I think most of these patients are happy to answer, honestly, because all they want at the end of the day is appropriate care. Most patients really want to make sure that you're not being nosy and that you're not judging them. Just from a personal example, which I think we probably all have had, the PA one time went to go talk to a patient, the nurse talked to the patient, and that patient said they were straight to both of those individuals. When I went in, I asked the patient again, and I added the disclaimer, like, I need to know your sexual orientation, because that changes the way I'm going to screen you. That increases your risk for certain things, and I want to be sure I'm appropriately treating you. Once I gave that little bit of a disclaimer, then the patient opened up and felt more comfortable coming out to me. So I don't think it was anything magic that I did other than sharing why I'm using the information and why I'm asking the information to the patient. The important thing is, to avoid a lot of the judginess or nosiness that these patients can sometimes get. I think that goes especially true with the transgender population. Oftentimes the transgender population has had several issues in the past with other healthcare providers that they may bring on to when they see you. Which leads us to the physical exam. It's very, very important to have appropriate draping, just as we all do with all patients, especially with this population. We know that transgender population has a very high rate of prior sexual abuse, both in partner and out of partner, with high rates of sexual trauma. So because of that, we want to be sure that we're very cognizant of this and aware that these patients may have PTSD from prior experiences, both sexual and non-sexual, and that they may be very, very physically uncomfortable with any type of exam. So we want to discuss that before we do the examination. Gender expression, as we talked about last time, remember, was how that patient shows the world who they are. Gender expression may differ from anatomy. So you may go in thinking you're going to expect one set of genitalia and realize when you do your exam is something very different. Remember, kind of expect everything whenever you see any patient, especially when you're seeing a transgender patient. Really, you may not know what you see underneath that sheet until you lift the sheet. The medical history may also change the exam. A specific example of this is a transgender woman who is taking steroids, may physically still have a prostate, but you may not be able to feel the prostate. As we all know, that prostate tends to shrink quite a bit on hormonal therapy. So that patient would want, we want to be very careful of our exam to pay particular attention to any prostatic tissue that we can still feel for this trans woman. From a surgical standpoint, it's really important to identify patients before we do an operation, because that may or may not change our surgical approach. I have a couple of things here that, just considerations. I don't know that there's any data for real to say that we should or should not be doing this, but it's just something to consider. Let's take, for instance, an anal staple line, be that from a hemorrhoid PPH procedure or a coloanal stapled anastomosis or a J pouch. With anal staple lines and someone who has anal receptive intercourse, will that interplay with their ability to have intercourse? I'm not sure there's an answer, but that's something we definitely want to discuss with the patient. And if there are any limitations, especially early on, we'd be sure we identify that with the patient. And I do tell them initially, especially after an anal anastomosis, don't receive anal sex until you get an okay for me. I want to be sure that, just like any trauma is not, damaging my recent anastomosis. So I'd like to be sure that everything's well healed before I allow them to resume anal intercourse. Apart from the actual physical construct of the surgery, sometimes the operations itself have significant impacts in these patients. The risk of incontinence is quite high in some patients in this population. So we want to be sure that we're very cognizant of how much biopsy we're doing, how much resection we're doing in a population with already standing risks of incontinence. Likewise, scarring and stricture are issues that we had to consider after our surgical procedure to be sure that these patients can continue on with their quality of life. As we all have, I'm sure many patients have said to you, just make it pretty, as soon as you're done. And I think they're referring to some of the scarring and that disfigurement that can be associated with our procedures in the perineum. Radiation is the one that I see the most. So I think as surgeons, we all have a love-hate relationship with radiation. We love it because it does such a great job of curing our cancers, but the side effects sometimes are something that linger in our clinics with little that we can do to help. And in this population, it's the same. So when the radiation does cause some degree of proctitis or bleeding or pain in these patients, it becomes even more difficult to treat. So the radiation proctitis in the patient who is not using their anus and rectum for anal receptive intercourse is difficult. Imagine this patient population that is using it for anal receptive intercourse, then we have a much bigger problem. So we talk about this before they start the therapy, before they start radiation. We talk about proctitis and we talk about stricturing. Just like with the women, I invite them to use dilators during their therapy. With the men and women who undergo radiation and who engage in anal receptive intercourse, I do recommend that they use anal dilators as well. We offer significant support when it comes to social and family. Not every patient has this. So for instance, if you have a patient that's undergoing therapy and needs radiation, just because we're talking about it, and needs to be able to come to the radiation oncology office every day for the next 5 weeks, that's a pretty big ask, especially if they don't have any family or social support. So this is something, again, that we need to talk with our patients about when undergoing and recommending different kinds of therapy, that they have a social backup. If they don't have this family or social backup to help them through this very difficult time, that's when we use we have nurse navigators or social workers or whoever you may have at your disposal to support this patient on their very arduous treatment plan ahead. And lastly, I just want to leave with a couple of experiences. These are actual quotes from physicians. I talked to you last time a little bit about a study that we had done looking at physician awareness and knowledge of LGBT issues. These are actual physicians and what they said after our surveys. We asked these physicians to describe any personal experiences treating gay patients that they may consider important or informative. One physician said, well, I simply just don't ask. Well, as we've talked about in the last couple of sessions, that's probably the wrong answer, but it's a very common answer. And somebody said, well, I treat them no differently than our heterosexual patients. And this is a tough one because, of course, you want to treat every patient the same. But when it comes to disparate populations, especially the gay population, we know that we can't treat them the same. They are a subclass. They are a special class of patients that need special attention for the reasons we've just been describing. So although we want to say we treat everybody the same, among LGBT patients, we should not be treating them the same. They need special attention in special areas that we should be considering very closely. When asked to explain any reservations they have in treating the LGBT population, most physicians, and this is pretty resounding, say that there's a lack of knowledge about the particular needs in care among the gay population. And this is something that I think many of us are working quite hard to fix, but this is something that only time and data will fix, and I don't think we're there yet. As we come up with more screening guidelines and surveillance guidelines for this special population, then we'll know a little bit more about how best to treat them. But until that day comes, I think we're kind of guided by small studies, individual experiences, and some consensus papers like NCCN and things like that. Another physician commented that I'm not sure why I need to know, again, underscoring the importance of treating these patients a little bit differently in terms of their high-risk nature. We asked the clinicians, what suggestions do you have for improving the cancer care of the LGBTQI population? Again, resounding information had to do with education. Educating both the patient and educating the provider, which is again why I thank the American Society of Colorectal Surgeons for having discussions such as this one, so we can educate ourselves on the specific needs of the LGBT patient and what we can do as providers to help them get the care they need. Somebody else said that we need to increase the education sensitivity to understanding that the needs of this population are necessary. And this goes beyond the clinical care. This goes, even within our institutions to the administrative level, to provide resources for these patients, such as specialized nurse navigators, such as specialized social workers who have training to help us better take care of this population. So those are the slides that I had for today, just to kind of overview the special cultural needs and clinical needs, rather, of this group. And wanted to open up to see if there's any questions, any discussion on any ways that we can jointly take better care of these patients, or maybe tips that anyone in the audience may have in terms of how we can take better care of our patients. All right, well, most of this is trial by fire, honestly. And if anyone can do the first step, what I would recommend, and I often get asked, well, what I'm interested in this, our hospital system is interested in this, what can we do? How do we start this? And my answer is always the same. And I would say, start with your EMR, start with collecting data. So many hospitals are starting to collect data on their SOGI, or sexual orientation, gender identity, of the patients. But some hospitals are not. So if you're one of the hospitals that has already started collecting SOGI data on your patients, mazel tov. If you're one of the hospitals that has not started collecting data on these patients, then I recommend that maybe that would be a great place to start. Most of the EMRs, Cerner and Epic, have this functionality. It just needs to be enabled. And whether that's done by your IT or by the corporate, enabling this data collection and then encouraging its use is one easy way to start. Because then at some point, you can go back and query your EMR to identify how many patients of a certain population you're actually seeing. And it becomes a queryable field in your EMR. So I think that's a great place to start, to identify how many patients you have with a specific population. I just focus on cancer care, but that can be going on, in multiple things that we treat as colorectal surgeons. How many gay men do we see with prostadentia? How many gay men do we see with, diverticulitis or benign disease, hemorrhoid disease, all kinds of things that we treat that may or may not need differential treatment based on their lifestyle. So I think that's where most of us as clinicians can start to identify these patients. And then to identify, secondly, ask ourselves, well, what am I doing in my practice that I should do differently for this population? If I standardly do a PPH for a hemorrhoidpexy, a staple hemorrhoidpexy, should I generally be offering this to all of my patients, or should I select out and offer something different to a gay man? I don't know the answer to that, but that's something that, I think each of us as clinicians can ask ourselves if there is room for us to change our practice unique to this population. And again, there are probably very few studies looking at this specific population and individual health concerns, but something that we can start off on an individual basis to determine how we can alter our practice and surgical care based on somebody's sexual orientation. Any questions or anything? Good. Well, again, thank you everybody for your time. I really appreciate everyone's the opportunity to discuss some of these issues with the group, and hope that it's informative. We're going to be doing a couple more of these coffee chats on different topics, so hopefully associated with the diversity issues that we all face every day. But this will conclude the LGBT proportion of it. So again, thank you all, and a shout out from Tampa, and I look forward to seeing everybody here for our annual meeting next year. Take care.